A pleasant evening to one and all present here. Thank you for joining us today. Today we have a very special PSM case presentation on diabetes mellitus, and for that we are very honored to have Professor Dr. Balaji Arumugam sir, HOD, Department of Community Medicine, Arunai Medical College, Tiruvannamalai. Sir, it's an honor to have you, sir. I invite Dr. Raghurandan Ramanathan to give his opening address.
Thank you, Parthiban. It's a great pleasure to have Dr. Balaji sir with us today. So he was my HOD and a wonderful teacher and one who I have learned a lot from him. And today it's our honor to have him here. So we have already a few of his lectures in our YouTube channel. We have epidemiology completely discussed, and that was really a wonderful session as we have got so many positive gratitude from the students before their exams, from starting from the last two batches. And thank you, sir, for once again joining with us amidst your schedules. And today we are starting with the first session for the year in community medicine. And this is going to be a case presentation by Tamilarsi, I think MMC student. I thank her for her bold attempt to present a case in the online forum. Thank you, Tamilarsi. And I thank once again Balaji sir for coming forward for this wonderful discussion. Thank you, Parthiban, for inviting me, and it was a great pleasure to have everyone here. Thank you once again, sir, and thank you, Parthiban.
We have Tamilarsi, a third-year student from MMC, to present the case. You can start. Sir, can we start?
Hi, good evening, one and all. Thank you so much for the invite, Dr. Raghunandan and Parthiban. Tamilarsi, I think we can go ahead with the presentation. If you are ready, we can go ahead with your presentation. Am I audible, Dr. Parthiban? If there are any audio issues in between, please let me know, okay?
Okay, so sure.
So your video is not on, sir.
I didn't switch on the camera, Raghu. Today?
No problem, sir, if not.
That's why I told you, no, I'm just keeping that camera very close to
Okay, sir. Okay, sir. Okay, sir. No problem, sir.
Good evening, everybody. Thank you for this opportunity, Medusane. I would like to thank Professor Dr. Balaji Arumugam sir, Professor HOD of Community Medicine, Arunai Medical College, Dr. Raghunandan sir, and Parthiban sir. So today's discussion is on diabetes mellitus. A 37-year-old male, a carpenter from 1/136 Elumalai 3rd Cross Street, Nanmangalam, Chennai 600113, Mr. Uma Mageshwaran, came with the chief complaints of stomach pain for 3 days and complaints of painful urination for 3 days and complaints of vomiting.
Sorry to interrupt. Can you please turn into that slideshow mode?
Exactly. You can also start from the beginning of the slide, because this is somewhere from general examination, Tamilarsi. So you please start from the first slide.
Sir, is the screen visible?
Screen is visible, but you have not changed the slide.
Okay, sir. So second slide visible, sir. History of presenting illness.
No, still it is there in general examination slide.
No, it's not visible.
Please go back to the first slide and then start from the slideshow. Yes.
Yeah.
Now the slide has got changed. Maybe you can just start a full slideshow so that it will be more visible.
Is it visible, sir?
Yeah, now it is visible, ma. Can you go ahead with the slideshow, full slideshow, so that people can view the entire slide?
So I think it is in slideshow.
Am I right, Parthiban?
Yes, sir. Slideshow mode. Tamilarsi, please press F5 in your keyboard.
So is it visible now, sir?
Yeah, it's visible now. Okay.
Now it's clear, ma. Now.
Shall I proceed, sir?
Yeah, please start. Please start. Yes.
A 37-year-old male, a carpenter from 1/136 Elumalai 3rd Cross Street, Nanmangalam, Chennai, 600117. Mr. Uma Mageshwaran came with the complaints of stomach pain for 3 days, complaints of painful urination for 3 days, complaints of vomiting for 2 days. History of presenting illness. The patient was apparently normal 5 days back. He developed abdominal pain, burning, micturition, vomiting, for which he was referred to Rajiv Gandhi Government General Hospital from Tambaram Siddha Hospital. The patient was admitted on 11th May. History of abdominal pain for 3 days in the epigastric region, which was intermittent, not radiating, not associated with abdominal cramps or abdominal distension. It was of sharp and squeezing type. History of vomiting for 2 days, only at night after food intake. Vomiters contained only food particles, no bilious or not blood stained. History of burning micturition. The urine is foamy for 3 months, and there is no history of increased frequency of urination, no history of oliguria, no history of hematuria, no history of dysuria. History of blurring of vision for 1 year, history of pitting edema for 1 week, no history of hematemesis, no history of fever. No history of acute weight loss, no history of dementia, no history of loss of vision, no history of seizures, no history of coma, no history of altered sensorium, no history of syncope, no history of chest pain, no history of palpitations, no history of periorbital edema, and no history of trophic ulcer. No history of polydipsia, no history of polyphagia, no history of loss of digits, no history of loss of tingling or pricking sensation, no history of loss of sweating, no history of claudication pain, no history of abscess, no history of non-healing ulcer, no history of dental caries, no history of gingivitis, no history of slurring of speech, no history of easy fatigability. Past history. The patient is a known case of diabetes mellitus for past 2 years and hypertension for 1 year. History of stroke 6 years ago and was treated at Chettinad Hospital. There is no history of asthma, epilepsy, tuberculosis, or thyroid disorders, and no history of blood transfusion, and no history of previous surgeries. Diabetes mellitus was diagnosed at a private clinic near at his home, and his glucose level are monitored every 3 months. Treatment history. The patient is on oral hypoglycemics and antihypertensives. The patient takes irregular medications. Previous records of medication treatment are not available with the patient, and the patient is currently on tablet enalapril 2.5 milligram twice a day, morning and night. Tablet spironolactone 25 milligram once in the morning. Tablet nifedipine 10 milligram 3 times a day. Injectin pyperacemin 2.25 grams IV 4 times a day. Tablet metformin 500 milligram twice a day, morning and evening. Personal history. The
One
patient.
second, Dr. Tamilarsi, can I have a few questions on the so far the history that we have presented so far?
Yes.
It's very good general complaints with presenting illness and past history and treatment history. You have narrated very nicely.
Yes, sir.
I would like to know a few things about the patient history. You said the history of stroke 6 years ago. Now the patient age is around 30 plus, isn't it? 36 or
37, sir. Yes, sir.
Okay. Did you the patient is you said that underwent treatment in Chettinad Hospital, isn't it? 6 years ago,
Yes, sir.
right?
Yes, sir.
Which means like what is the status of his paralysis? You mean to say the patient was suffering from hemiplegia or something else, or just can you tell me a little bit more about the history of stroke 6 years ago for this patient? Do you have any details about that?
Sir, he was stable when I examined him, sir.
Okay.
All his muscles, everything.
Okay.
But about the history of stroke, he was not very convenient to tell me, sir, though I inquired
check,
very well.
okay, fine, that's good. Did you have check any of his past reports or something like that?
So that was not available with him when he came to this hospital.
Okay, so far, according to your presentation with the symptom analysis, a 37-year-old male patient presented with symptoms of urinary tract infection and known case of diabetes for the past 2 years.
Yes, sir.
And also had a history of stroke so far.
Yes,
Any other positive histories? You have narrated very nice negative histories, Tamilarsi.
Yes.
Any other positive histories or any other positive symptoms?
He had pitting edema, sir.
Yeah, pedal edema is there. Both bilateral or unilateral?
Bilateral, sir.
Bilateral. Okay, okay. What is the significance of knowing a bilateral pedal edema in a 37-year-old male?
It can be due to hypertension, sir.
Okay. What other things can cause bilateral pedal edema for a 37-year-old male patient presenting with diabetes and hypertension? Hypertension also is an hypertension also. He is a known case of hypertension also, isn't it? Right?
Yes, sir.
Okay. Any other details related to his cardiac conditions?
No, sir.
No, nothing. Okay, then you proceed, Kamlesh.
Okay, sir. Personal history, the patient consumes mixed diet, no history of alcohol intake or smoking, no history of substance abuse, no history of IV drug abuse, normal bowel or bladder habits, normal sleep-wake cycle. He takes 7 to 8 hours of sleep. And diet history was calculated by 24-hour dietary needle call method. This is his diet plan, sir, for the past day. And the patient consumes 1064 kilocalorie per day against expected 1200 kilocalorie with deficit of 136 kilocalorie. The patient consumes 28.8 grams of proteins per day against expected 57.6 with a deficit of 28.8 gram of proteins.
How did you arrive at that 1200 kilocalories, Kamlesh, for this patient?
Sir, expected body weight height minus 100, sir.
Okay.
Then I went to the dietitian and asked about how to calculate the diet history for a diabetic patient.
Okay.
Then they gave me the value of 25, 30, and 35 for obese, normal, and overweight patient.
Okay.
And 0.8 must be multiplied for men and 0.9 must be multiplied for women with the ideal body weight. Sir.
That calculation is very good, but apart from all these things, for this pre-final stage, you can even directly get to know from the recommended daily allowance from the textbook, recommended daily allowance for this particular patient. Do you think that this patient is a moderate worker, heavy worker, or sedentary worker?
So now he is sedentary, sir.
Now he is sedentary only. What is the recommended daily allowance for a sedentary worker male? It's almost close to 1200 only. That's what I'm trying to say, right? The way that you calculated with the help of dietitian is good only, but yes, there is a direct way of knowing the recommended daily allowance based on sedentary worker, moderate worker, and heavy worker. Okay, these definitions are very important, right? Okay, do you know anything about the definition of sedentary worker or something like that? Do you know anything about sedentary worker, moderate worker?
Sedentary worker, IT professionals.
Okay, those are all examples. Very good. Do you know the definition of sedentary worker, moderate worker?
With least exercise, least body movements.
Okay, good. You are coming too close to the answer. Very nice, and with the examples also, it's very nice. What about
heavy workers?
Heavy worker
who does so much of physical works like weightlifting.
Okay.
Movements. Like farmers.
Yes. Okay. So you need to know about two things when you are calculating socioeconomic status, and also when you are trying to find out the recommended daily allowance. You are supposed to know about the nature of job of the patient. So according to the nature of job of the patient, only you can divide them into which type of worker, one thing, and also you can also divide them into skilled, semi-skilled, and unskilled worker. Right? Have you heard of all these things? Skilled,
yes.
Semi-skilled, and
yes, sir.
Unskilled. Okay. Go ahead.
Yes, sir.
Yes.
The family is of nuclear type with 2 family members. The patient's father was diabetic, but he is no more, sir.
Oh.
Now he lives with his wife and they are expecting a child, but she's not pregnant. They're married only for 2 years. The total family income is 30,000. According to modified Kupasamy scale, the family comes under upper lower class. And there is no history of similar illness in other family member. Okay. And no history of any vital events, sir.
What are the other socioeconomic status scales that you know, ma'am?
So, BG Prasad scale.
Very good.
And Uday.
Yeah, tell me. No problem. See, modified Kupasamy scale has got 3 components. What are the 3 components? These are all very commonly asked questions. What are the 3 components of modified Kupasamy scale?
Education, occupation,
and income of the
family.
Based on that, you would divide them into three categories, right? So you have education head of the family scoring from 7 to 1 and occupation head of the family scoring from 10 to 1. So based on the scoring, right, what is the final score that this family has got or this patient has got according to modified Kupuswamy? Any idea?
10, sir. 3,
10.
3, 4, sir.
Okay, fine.
Education 3, monthly income 3, and occupation is 4.
Okay, what is the advantage of modified Kupuswamy scale? Modified Kupuswamy scale mostly
Can be used for both urban and rural.
Yeah, good. But what is maybe you can do you know about this one Parik classification? You know?
So Uday Prasad.
Uday Parik classification.
Yes, sir. Yes, sir. I know the name, sir, but
yeah, I'll tell you. Uday Parik classification is also a type of socioeconomic status classification, mainly used for rural areas. Okay. So it
okay.
has characteristics, different characteristics, but the important thing is it includes caste, occupation, education, level of social participation, land holding, housing, farm power, many things are there. Almost 8 to 9 components are there in Uday Parik classification. It is mostly used in rural areas. But for you, for MBBS graduates, for presenting a pre-final case presentation, you need to present at least, you need to use modified Kupuswamy as well as modified BG Prasad. Okay, right?
Okay.
Go ahead. Now, do you know what is the purpose of using socioeconomic status? What is the meaning of, I mean, the purpose of assessing the socioeconomic status in case presentation of community medicine?
How well the schemes are reaching the patient and how well they can use it.
Okay. Then?
Based on the family income, how they can avail the services.
Then? Which means affordability. You need to know about the affordability. Okay.
Yes,
right?
sir.
And you need to know about any disparities. Okay, right? If there are huge disparities existing because everything, primary healthcare is mainly focusing on imparting equitable distribution, right? And
Yes.
to know about the affordability and to know about any huge disparities existing. Okay, right. Go ahead.
Water supply. Can water is used for drinking and 1 can is used per day. It is costing rupees 15. For other purposes, well water is used. The water is not boiled before use. Drinking water is stored in copper vessels and it is kept closed. The toilet is separate outside the house and there is no open air defecation. Water seal is present. Type of latrine is, they have both RC and Western type. Open drainage is absent. It is drainage is through septic tank, and the floor of the toilet is tiled and it is dry and clean. Bathroom is separate. Tap water is used and it has tiled floors and it is not slippery. Waste disposal, solid waste. There is no segregation of waste, but it is closed and kept in dustbins and it is disposed every day and it is collected by the municipality workers and there is no dumping of waste near their house. Liquid, no sewage or sewage separation and it is disposed into septic tanks, sir. Peri-domestic area, setback is present, sir. No waste or garbage outside the house and no water collection spots.
What do you mean by setback, ma'am?
Area around their house, sir.
Open space, open around the, okay, right. Continue.
No pet animals or no cattle or poultry. Personal hygiene, practice of hand washing is practiced, sir, after toilet usage, before cooking food and before eating food.
Did you assess what type of house this patient is?
Pakka house, sir.
What do you mean by Pakka house?
Roof is concrete and the walls are concrete. Floor.
Two things are very important, right? Whenever you ask about the environmental history, this in and around the houses, first one is it starts from the type of house, right? So Kacha house means like thatched roof with mud walls, and semi-Pakka is tiled roof, and Pakka is cemented roof and walls. Okay, right?
Yes.
Did you assess the lighting and ventilation? Because
yes.
Postgraduates only will go to the house and see the patient's house and all, right? So whatever the thing that you ensured is everything from the patient only, isn't it? You have taken the case from the field or you have taken the case from the hospital?
So from the hospital, sir.
From the hospital. Can you define adequate lighting and adequate ventilation?
Adequate lighting without current lights or any other light, the patient must be able to read sitting in any corner of the house.
Very good, fantastic. What is the meaning of adequate ventilation?
With windows open and doors open, there should be enough air, sir.
Yeah, so every living room should be provided with at least 2 windows, and one of them should open directly to an open space, right? Because the adequate ventilation is very, very important factor. Why are we much worried about this adequate ventilation? We are very much worried about the indoor air pollution, especially in urban and semi-urban areas. Okay, sorry, especially in urban slums, right? And one window should open in the directly to the open space. That is called as adequate ventilation. What is cross ventilation, ma?
The door and the window must face opposite end.
Good. And the air also should pass through one end from other end. Okay.
Yes.
Did you assess the overcrowding in this family?
And only the patient and his husband is
So,
present.
the other criteria that is most commonly used for assessing overcrowding, do we have any association between overcrowding and diabetes in this case?
So, overcrowding is mostly associated with communicable diseases,
Yes.
but if it should be associated with non-communicable diseases, it can associate with hypertension, sir.
Hypertension, stress, and also mental health disorders. Okay.
Sleep disturbances.
Very good, very good. Go ahead, ma'am.
So the roof is concrete, weatherproof, damp-proof, no cracks and crevices, no water leakage. 4 windows, sir. Cross ventilation is present, adequate lighting. Kitchen is separate. Cooking platform is present, separate washing area is present. Exhaust ventilation is present and no indoor air pollution. Type of fuel is LPG, no fly or cockroaches. Shall I go to general examination, sir?
Now, before going to general examination, Tamarasi, sorry for stopping in between so much time. So far, you are answering nicely for the general questions most commonly asked for any case presentation in community medicine, right?
Yes, sir.
Before going into further general examination, can you summarize the entire history or only present only the positive histories, Tamarasi?
Blurring of vision, vomitus.
Start from the age, age of the patient.
Okay, sir.
You're presenting a summary. A 37-year-old male.
Yes. Patient Dr. Uma Mageshwaran, 37-year-old male, hailing from Nanmangalam, Chennai.
Yeah.
He's on irregular medication. He came with a complication of urinary tract infection. He's hypertensive with risk factors of diabetic father and reduced physical activity. He belongs to nuclear family, upper lower socio-economic status by modified Cooper-Samy scale, and calorie and protein deficit of 136 kilocalorie and 28.8 gram protein respectively.
Okay, no problem, Tamarasi. But what you should have done is, this is actually a case overall community diagnosis or clinical diagnosis, okay, or social diagnosis. So,
yes, sir.
You are presenting in the examination. This is for all the students, those who are listening to the presentation. Whenever you present the complete history, you summarize the history alone. Don't even go for diagnosis, right? Just present it with a 37-year-old male presented with so-and-so complaints. And with a presenting illness, he has presented these complaints, having a past history of stroke and hypertension and whatever. Then proceeding with in this urban slum or whatever, then modified Kupusamy scale based on what are the socio-economic status, and having a good environmental condition, a better environmental condition, and calorie requirement. So up to this overall history, you present it and stop it. Okay, then you proceed with general examination. Okay, this is what I expected from you. So whenever you are asked to summarize the history alone. Okay, then you proceed with general examination. That's what I expected from this. Just a modification before, because after this history presentation only, you will start general examination and going in for systemic examination and diagnosis, right? So history,
yes,
but don't tell the diagnosis a lot, just the symptom analysis. Okay, right? Now you start with general examination.
Yes. Patient is conscious, oriented to time, place, and person.
Yes.
Present, bilateral pediatric pitting in nature, no icterus, no cyanosis, no clubbing, no lymphadenopathy, no visible veins or visible swelling or surgical scars. Vitals, pulse 90 beats per minute. It is normal volume, rhythm, and normal rate and regular rhythm. Peripheral pulses were not felt. Respiratory rate 14 breaths per minute. Temperature was afebrile to touch. BP 110 by 70 mmHg was measured in sitting position, taken in right upper arm. Anthropometry, height 160 centimeter, weight 55 kg, BMI 21.48 kg per meter square. Systemic examination. CVS, S1 and S2 heard, no murmur, no added sounds. RS, normal vesicular breath sounds were heard. Abdomen was soft, non-tender, no organomegaly present. CNS, no neurological deficits. And skin, no significant skin changes seen. No acanthosis nigrans, no boils, gangrene, no ulcers. Ocular visual acuity of right eye using Snellen's chart 6 by 36, left eye 6 by 124, no corneal arcus, pupillary reflex is present on both eyes, fundus examination was not done. Foot, callus or cones, skin breaks present, nail appears normal, no ulcerations, no any amputation, no previous foot ulcer. Case summary. Patient Mr. Uma Mageshwaran, 37-year-old male, hailing from Nanmangalam, Chennai with type 2 diabetes on irregular medication, came with the complication of urinary tract infection, hypertensive with risk factors of diabetic father and reduced physical activity, belongs to nuclear family, upper lower socioeconomic class by modified Kupasamy scale, calorie and protein deficit of 6 kilocalorie and 28.8 grams protein respectively. So clinical diagnosis, a case of diabetes mellitus with urinary tract infection.
I have a few questions before we further move on to investigations. Tamilasi,
Yes.
okay, this thing is, you have measured the anthropometric measurements. What is the purpose of having an anthropometric measurement for this patient?
He has DMs, so we should calculate BMI and compare for obesity causes.
Dealing with the case of non-communicable disease, probably at a case of type 2 diabetes, definitely we need to know about his body mass index, right? So which means you are trying to measure or we are trying to assess the obesity. What are all the other methods of assessing obesity? Apart from body mass index, am I audible?
Yes, sir. Yes, sir. You're audible, sir.
What are the other methods of assessing obesity apart from body mass index? Do you know any other formula or calculations, or do you know the WHO classification of body mass index? You said bracketly, you have put it as normal for this patient, isn't it? Right?
Yes, sir.
So what is how do you classify obesity based on BMI?
Underweight, normal, overweight, obese.
Very good. So what is overweight and obese? The classification based on BMI. We have two important classifications. One is WHO classification. Another thing is our Asian ICMR classification. Okay, please go through both the things. And you have classified this patient as normal. It's good. So the BMI ranging from 25 to 30. Exact numbers, please be specific. 25 to 30, we call it as overweight and obesity. And 30 to 35 and 35 to 40 and more than 40, we call it as morbid obesity. This is WHO classification. Okay, right?
Yes.
Based on body mass index. What are the other measures of assessing obesity? What is android and gynoid obesity, Tamilasi? Any idea?
No, sir.
No, I'll tell you. So this, especially whenever you are encountering a case of chronic disease or non-communicable disease, especially diabetes and hypertension, the most common question being asked is about obesity. Now, android obesity and gynoid obesity. So in order to assess android obesity, in addition to body mass index, we should have used waist circumference, hip circumference, and waist hip ratio. This is very commonly used measure of obesity apart from body mass index. Please note down, this is very important. So this waist hip ratio and waist circumference, especially the waist circumference, right? Please put down the anatomical landmarks for assessing waist circumference and measuring hip circumference, and based on that we classify waist hip ratio, right? So if the waist hip ratio is more than certain numbers, and especially waist circumference, then the patient is having abdominal obesity, right? So when the patient is abdominal obese, especially in the case of android obesity, especially it happens in males. So android obesity, they are more prone for syndrome X or insulin resistance syndrome. Do you know what is insulin resistance syndrome? Or we call it as a metabolic syndrome?
Yes, sir.
Yes, tell me.
Components
of insulin resistance syndrome.
The cells are not sensitive to insulin, sir.
Yes, that is, so your fat cells are not sensitive to insulin. Thereby it happens hyperinsulinemia, hyperglycemia, hyperlipidemia, hypertension. Sometimes it goes for cardiovascular disease or ischemic heart disease, and sometimes it leads to stroke. All these things are called as, we call it as syndrome X or insulin resistance syndrome, or it is called as metabolic syndrome. So in order to assess not only the type 2 diabetes, whether we are dealing with the case of metabolic syndrome or not, we need to assess the obesity more carefully. Apart from using BMI alone, I would suggest even for MBBS graduates to assess obesity based on waist hip ratio and waist circumference. Okay, this is one point I would like to suggest, so that you classify them into android obesity or gynoid obesity. So android obesity is nothing but more of fat accumulation around abdomen. Okay, gynoid obesity is nothing but more of fat accumulation around buttock region and thigh region. Okay, right? So both the obesities are dangerous, but the important thing is android obese people are more prone for metabolic syndrome. And that is the reason I would suggest my medical graduates to assess obesity not only with BMI, also with waist hip ratio. Okay, ma? And this is the most common question, my dear students and audience. Measures of obesity is the most commonly asked viva question and case viva question whenever you present a case to assess or classify metabolic syndrome. Okay, right?
Yes,
This is
sir.
about anthropometry, Tamil. I would like to go back to the previous slide. Before the anthropometry, I would have, before the, no, general examination. Yes, you have done very nice general examination. Can you tell me the WHO measurement of blood pressure? You have measured in sitting position, taken in right arm. Very good. How many measurements that you have done, you have taken, Tamil? Usually, how many should we take? And this is also a hypertension patient, isn't it?
Yes, sir. To confirm hypertensive, we should take 3 times, sir.
3 times, okay. You always try to have at least 3 measurements in university pre-final examination. Even if is normal blood pressure also, patient is having normal blood pressure also, please measure at least 3 measures. Measurement 1, 2, and 3 taken 5 minutes apart. That is a WHO recommended measurement of blood pressure. This is very important for, these are all basic things, are always basic for MBBS graduates. Even though the patient is a normal blood pressure patient, please take at least 2 or 3 readings. WHO recommends 3 readings. Okay, ma? Right? This is one thing I would like to add about blood pressure measurement. Do you know what is rule of house?
Rule of half.
Rule of house.
Half of the patient is diagnosed, half takes the treatment. Is that so?
Exactly.
Half of the patient is diagnosed, half of the patient knows the symptoms, half comes to get treated, half gets diagnosed, half follow up comes for the follow up. That is
See, that much of iceberg is still there. Okay, right. Do you know when is the World Hypertension Day?
no, sir.
No. 17th of May, just 2 days before. 17th of May is World Hypertension Day. Okay, right? So our Tamil Nadu data says that 40%, close to 33.9, almost 34% of the people are hypertensive. So hypertension, diabetes, all non-communicable diseases are iceberg disease. Do you know what is iceberg phenomenon?
Yes, sir. Only some part of the people are diagnosed and large part of the eyes, as it is emerged, many of the cases are undiagnosed.
Exactly. So what the clinician sees is only the tip of the iceberg. That's what I'm trying to say, right? What we see as a clinician in the hospital is only the tip of the iceberg. Okay, right? So the undermined portion, especially the waterline, below the waterline, there are huge undiagnosed people are there. Okay, right? So அதோட modified version தான் this rule of house. Okay, right?
Okay, sir.
Fine. Proceed with your anthropometry. We have finished the discussion, and you have done very nice foot examination. Very nice foot examination, Tamilarsi.
Okay.
But I really appreciate that. Okay, please go ahead for the investigations.
Investigation: fasting blood glucose sugar, postprandial blood sugar, HbA1c, complete blood count, lipid profile, electrolyte, urine glucose, urine albumin, ketone bodies, ECG echo, fundus examination of eye, RFT, LFT, sensory loss nerve conduction study, GFR, X-ray, ascites and pleural effusion. Routine follow-up investigation, FPS, PBBS and HbA1c. The first two every 3 months, HbA1c every 6 months, ECG echo and fundus examination annually.
What is the role of HbA1c here, Tamilarsi?
HbA1c, the RBC lifespan is 120 days. So every turnover we can accurately measure the glucose level of.
So it gives you the long-term measurement of blood glucose. Okay,
Yes.
Okay, fine. Okay.
So advice at the individual level to the patient must strictly adhere to the drugs, and the advice regarding the warning signs of hypoglycemia like giddiness, convulsions and blurring of vision and unconsciousness, and to timely report for the same. So the person should carry an ID card showing name, address and phone number and details of the treatment currently receiving, and candy or chocolate, and adopt lifestyle modification, brisk walking. Diet, reduce the salt intake for less than 5 gram per day, and use groundnut oil for cooking or mix of oils. Mix of oils as in sunflower oil, groundnut oil one day, and avoid hyperglycemic foods like banana, mango, grapes, and avoid frank sugar. Eat frequent small meals and add pulses to diet to make up for the protein. And self-care, he should take responsibility for his own care.
Do you-
Adherence to
Sorry
yes,
to
sir.
interrupt, Tamara. Regarding the dietary advice, whatever the points that you have mentioned is very good. As an examiner, I would like to ask one question regarding this one. Do you
Yes.
know the concept of prudent diet?
Sir?
Prudent diet. Do you know the concept of prudent diet?
No, sir.
Dietary goals for prevention of non-communicability. You have mentioned 2 points you have already mentioned. Reduce salt intake to less than 5 gram per day. And those some 5-6 points are there regarding dietary goals for prevention of non-communicable diseases. Okay, right? Do you know what is rule of 100?
No, sir.
No problem. So rule of 100 is nothing but when you are suggest advising the patient, they are supposed to maintain the blood sugar level at 100 and also blood cholesterol level at 100, and they should walk per 100 this thing per. So all these things are included in rule of 100. These are all general common questions, right? You have mentioned in dietary advice, and similarly, you are supposed to know about prudent diet and dietary goals, okay, for prevention of non-communicable diseases. Good. Go ahead with self-care.
Adherence to diet and drug regimes, and attending periodic checkups and
Very good.
recognition of symptoms.
Okay.
Regular examination of food by putting one or the other and examining food blisters, cuts, or ulcers. Always dry the web spaces and cut the nails frequently. So for the family, we suggest for individual screening and motivate the patient to develop positive attitude and go for regular checkups, and to motivate the patient to adhere to proper diet and treatment. At community level, early diagnosis and prompt treatment to lead a healthy lifestyle, regular BP and weight checking, blood sugar level, especially after 40 years of age. Health education is given to the community through information education about the cause, cure, and treatment and availability of services. So the level of prevention failed in this case is secondary prevention. And the programs for diabetes mellitus, National Program for Prevention and Control of Non-Communicable Diseases, and Makkalai Thedum.
Good, your presentation is so nice and you are involved, included, especially investigations, advice to all the levels is very nice. I really appreciate that portion of the case sheet, Tamarashi, especially for individual level, self-care, food care, community level, and also levels of prevention failed. You said levels of prevention failed is secondary prevention, right?
Yes,
so I would like to add a few points about levels of prevention. As everybody knows about primordial, primary, secondary, and tertiary. Could you tell us that whether this patient has got any complications of type 2 diabetes, Tamarashi?
he had blurring of vision.
So blurring of vision means it may know the complications of type 2 diabetes.
Complications can
Chronic type 2 diabetes.
retinopathy.
Yes, exactly. Retinopathy, neuropathy, nephropathy, all pathies because of chronic microangiopathy, right?
Yes,
so
sir.
you think that because the patient is having blurring of vision, he must be having early onset of retinopathy or something like that, isn't it? Right?
Yes,
so
sir.
you are suspecting the patient might be having some complications because secondary prevention also failed. So what is the importance of secondary prevention, Tamilarasu? The idea of secondary prevention is to diagnose the disease as early as possible before the disease process becomes irreversible.
So it can be adequately treated, sir, if it is prevented.
Absolutely. What you're telling is true. So that's what I'm just telling. In other words, you diagnose the disease as early as possible before the disease process becomes irreversible, which means during the early pathogenesis phase. Okay, right? There are two phases of natural history of disease we usually ask. So pre-pathogenesis and pathogenesis, isn't it? Do you know that, right? So in pathogenesis, you have two important phases: early pathogenesis and late pathogenesis, right? So already the patient has landed up in the failure of early pathogenesis. Now we have got only the tertiary prevention, right? What are the tertiary prevention measures possible for this particular patient, or in general? Could you tell us tertiary level of prevention, which means two things: disability limitation and rehabilitation.
Rehabilitation.
Right? Of course, so far the patient is not landed up in any disability, right?
Yes, sir.
Landed up in any disability. So still we have got some scope in secondary prevention. You can still control the hypo, especially the glycemic control is being maintained chronically so that the patient will not land up in any tertiary complications. Okay, right?
Yes, sir.
Anything else? Maybe some basic questions I would like to clarify from you. What are the difference between type 1 and type 2 diabetes?
Type 1 diabetes usually occurs in younger age groups
Yes.
where the cells are resistant to the insulin.
Type,
As type 1, the cells,
type 1 is because of absence of insulin. As you said, the age is a younger age onset, very younger age onset. This is
the beta cells don't synthesize the.
we call it as beta cell failure. Okay, that is type 1. Type 2 happens later part of life, and it mainly because of insulin resistance, because of excess fat cells, and because of this obesity and all. Okay, right? So basically
Yes.
between type 1 and type 2 diabetes, and also present it whenever you present the case, you complete it with whether the patient is having with or without complications. Okay, so you mean to say that you are suspecting some sort of complication may be there in this patient, right? Now, could you tell us what are all the risk factors for diabetes? Do you know the multifactorial causation? Multifactorial causation, especially in non-communicable diseases, various factors, precipitating factors will act at individual level, or it will precipitate one after another and result in a non-communicable disease. It can be ischemic heart disease, it can be type 2 diabetes, or it can be hypertension or whatever it is, right? So because there are multiple factors, you are trying to stop those factors, right? Could you tell what are the multiple factors present in this patient? He is not obese, isn't it, right? You said the BMI is normal. Okay,
Yes.
right? What are the other risk factors present in this patient? You have two groups, right? Modifiable and non-modifiable. Could you tell us about that?
Age and family history,
Yes.
it is non-modifiable.
He has a family history of because
A
his
diabetic family.
okay, right? Then any other non-modifiable risk factors? I mean, modifiable risk factors. These two are non-modifiable. Any modifiable risk factors present in this patient?
A food intake, diet.
Yes, exactly, right. And you said that he is also having a sedentary lifestyle, isn't it?
Yes, sir.
Is he having having any current occupation? Currently, is involved in any work like that, or after the stroke, staying at home only?
For 2 weeks, he has been at home only, sir.
Yes, for the last 2 weeks, he is at home only, right? Good. So, in order to conclude, Tamarasi, your presentation right from the beginning till your investigation and health education regarding individual level, family level, community level, and program level are all very nice presentation. Hats off to your presentation. Your case sheet is very nice. Good presentation. Keep it up, Tamarasi. So, before I conclude this case history discussion on diabetes, especially in community medicine, I would like to summarize certain few possible questions which most of the examiners are expecting in community medicine, right? Let us focus on community medicine aspect. So to start with, general questions I've already asked. If you are presenting a non-communicable disease, or it can be a case of hypertension, diabetes, ischemic heart disease, the most common examiners questions will be, what are all the risk factors present in this patient? Could it be a modifiable or non-modifiable? Okay, and second one, most commonly, the question asked is, are we dealing with a case of metabolic syndrome or just a case of hypertension or diabetes alone? Okay, right? And for that, you are supposed to know, you are supposed to assess obesity, not only using the body mass index, you should know various measures or assessment of obesity, other measures also. And basic questions are about type 1, type 2 diabetes difference and various gaps in non-communicable disease. There are 4 important gaps. We always say there is no agent, long latent period, all these things favor for non-communicable diseases, right? These are all the most common questions, and especially specific to hypertension, the questions are about tracking of blood pressure and this rule of House, complications of hypertension and complications of type 2 diabetes, right? So all these questions are commonly asked in non-communicable disease. Okay, right? And the programs, as you mentioned about the national program and also the Tamil Nadu level program, Makkalai Thedi Marutham, that is also a modified version of like house visits. Mostly the peripheral health workers, VHN or ASHA or any other peripheral health worker will go to the house, check whether these patients are regularly taking the medicines. Sometimes they used to measure the blood pressure, and with the help of glucometer, they measure the capillary blood glucose at the home and check whether they are taking the medicines properly. If they are not taking the medicines properly, they'll be insisted about drug adherence and they should follow the diet and all. These advices will be given by the peripheral health workers at the home level, at the community level. This is successfully going on. Even in my department in Arunagam Medical College, we are successfully following this Makkalik Thedi Marutham in a different format in our department using our own medical social workers. This is very, very important because we need to talk to these people again and again, create our awareness again and again to our community. Okay, right? And finally, I would like to thank Tamarasi for this wonderful presentation and Dr. Parthiban for coordinating this entire program, and also Dr. Raghunandan for giving this wonderful opportunity for discussion. Okay. Any other queries, Parthiban, Raghunandan, regarding this case presentation, I will like to answer, or if not, we'll close the session. Thank you.
If
Thank
you
you
guys
so
have any queries, please post it in your chat box.
So we will have the comments as we already have, sir. Like epidemiology, comments like it, they will be posting, sir. We will let you know, sir.
Okay, Raghu. Thank you. Thank you so much, Raghu.
Thank you so much, sir, for joining with us today, sir. It was really a wonderful session and very short as it is always in our channel by your lectures. It is like very short and it will be like very useful for the students before their exam. As usual, this session also, I guess people can even see a day before the exam. If they see also, it will be like very useful for them to present a case. And I hope in future we will have more case presentation organized by Parthiban. Thank you so much, sir, once again for joining with us.
Thank you. Bye.
Thank you, sir, for guiding me.
Thank you,
And for this enriching knowledge, sir. Thank you so much, sir.
Good, ma. Keep it up. Bye.
Okay, we'll end the meeting. Thank you once again, sir.